So we are the alcohol intake group, and we decided to focus on pregnant women in the United States. So as a brief overview of our presentation, we're first gonna address why and understand the health problem, which correlates to our part 2 assignment. We're then going to review existing evidence and what has been done, which correlates to our part 1 assignment. And then we are going to synthesize our evidence, conceptualize an intervention, and recommend approaches, which is associated with our part 3 assignment. So first, why and understanding the health problem.
The burden of alcohol intake during pregnancy is huge in the United States. 10 to 16% of women report alcohol intake in pregnancy, which is likely an underreport according to the CDC. The US suffers high economic costs from this burden. In 2010, costs were to the tune of $5.5 billion. Alcohol intake during pregnancy increases the likelihood of fetal alcohol spectrum disorder, a group of conditions that occur in a person who was exposed to alcohol before birth, and includes physical problems and developmental disabilities.
So the biological plausibility for this is as follows. Maternal alcohol intake results in a series of effects on maternal and fetal health. On the fetal level, alcohol has been shown to cause chromosomal rearrangements and epigenetic alterations. This can cause poor development of the central nervous system, affecting the continuous development of the child. With enough mutations, there's an increased risk of preeclampsia, low birth weight, and miscarriage during prenatal development. Children born with fetal alcohol spectrum disorder often have poor eyesight, hearing problems, poor developed bones, and organ damage. During early childhood development, this can also prevent the child from linking a behavior to a consequence, resulting in a multitude of academic and social problems. Chronic maternal alcohol consumption can also negatively impact maternal health with fatty liver disease, cognitive impairments, high blood pressure, heart disease, and stroke. These long-term and intensive consequences encourage us to develop an intervention around alcohol use in pregnancy. To create an equitable and effective intervention, we first evaluated the risk factors of alcohol consumption during pregnancy. Alcohol is often a social activity, and alcohol consumption during pregnancy is a result of a multitude of levels of the social ecological framework. At the individual level, some determinants of mechanisms of action include education and pre-existing health beliefs. Education is vital in the decision-making of the process of an individual. According to the cognitive theory of learning, learning is about acquiring knowledge and skills and having them in memory to take actions based on this information. Lower levels of education are also associated with higher risk for developing alcohol dependence. This is important in the prevention of alcohol consumption during pregnancy, as it states that those exposed to potential negative consequences of their actions are less likely to perform the negative action. Another determinant in this level is an individual's pre-existing health beliefs. Particularly in the context of alcohol consumption, an individual may have personal beliefs about the consequences of alcohol consumption in or out of pregnancy state. The health belief model, in combination with cognitive theory of learning, makes this a very actionable determinant for preventing alcohol consumption.
At the interpersonal level, supportive primary relationships and patient-provider relationships are very important. A supportive primary relationship with a partner has been shown to decrease alcohol intake among pregnant women. The patient-provider relationship is also important to bring brief interventions for pregnant women to be educated, counseled, and empowered to make their own choices surrounding pregnancy.
At the organizational level, admitting to alcohol use can be stigmatized. If a newly pregnant person admits to alcohol use and is subjected to child welfare services upon providing a urine sample, they may lose trust in their medical provider. Lack of access to culturally specific providers is another organizational determinant. Programs that involve community input for treatment may be more effective in engaging with target groups.
At the community level, neighborhood alcohol outlet density and cultural ethnic factors can impact a pregnant woman's drinking behavior. More bars and restaurants that serve alcohol increase accessibility and likelihood of alcohol consumption. Different cultural and ethnic groups may have varying attitudes towards drinking during pregnancy due to traditions and customs, which in collectivistic cultures emphasize intake over potential harm from alcohol use.
At the societal level, housing instability induces stress that can increase alcohol consumption while pregnant. Women who were the most exposed to housing instability, mainly low-income and African-American women, endure greater pressures during their pregnancies. Another determinant that impacts alcohol consumption are the policies currently in place regarding pregnant women and alcohol. Pregnant women suffer from punitive policies because these policies don't encourage the resources and programs in place to decrease alcohol consumption in pregnant women, but rather intervene after more serious consequences have occurred, such as CPS intervention.
So next, we are looking at what has already been done. To better understand what work has already been done, we conducted a meta-analysis. The first review of the digital interventions for pregnancy included 6 randomized controlled trials with sample sizes ranging from 48 to 459 and participants averaging 24 to 36 years of age with varying ethnicities. 2 interventions delivered digital content via text, while the others used computer or internet methods. Follow-up assessments were conducted 4 to 28 weeks post-treatment. Looking at the results, exposure to interventions resulted in a decrease of over 50% in alcohol intake during pregnancy, indicating high effectiveness. However, limited studies in the meta-analysis and self-reporting bias may have affected the results. And additionally, some interventions focused on overall baby health tips instead of just alcohol intake specifically.
Psychosocial interventions in the second review, 16 of which were individual randomized control trials and 4 cluster trials. The sample sizes range from 41 to 2,235 people, with ages ranging from 18 to 37 years and differing ethnicities among studies. The time ranged from 2 weeks to 60 months. Most of the reports were of poor quality, and the 6 that were analyzed showed effectiveness. Those in the intervention group had 2.31 times the odds of abstaining. Specifically, brief interventions with motivational approaches were effective for heavy drinkers, and multiple sessions were effective for low-level drinkers due to repeated messaging. Low-level drinking at baseline hampered the effectiveness of the brief interventions, and there was also a risk of underreporting of alcohol intake due to social desirability bias, recall bias, fear of consequences, and mistrust of clinical settings. One of the studies used an objective hair segmental analysis rather than a self-report to evaluate alcohol intake after intervention, which promoted effectiveness.
So some research gaps that were found within these 2 studies include the lack of socio-demographic factors such as race and economic status, which were not fully assessed within these interventions. Cultural differences that lead to stigma surrounding alcohol intake among various ethnicities also requires further research. And lastly, as Paula mentioned, under self-reporting, which can lead to gaps in research, but this can be mitigated through biomarker tests such as the hair sample mentioned prior. And to examine the health equities that were and were not addressed through these interventions. First, in the study 1, disparities such as race were not addressed in the participant demographic pool, which will lead to exacerbations in the disparities. And in study 2, social demographics such as economic status were not addressed either. All studies included mothers of low socioeconomic status, with the majority of Black ethnicity, thus exploring behavior change techniques within that group, but mothers with high economic status may have been overlooked. Social determinants and environmental factors were not addressed either. None of the interventions focused on reducing negative emotions related to alcohol intake as a coping mechanism. And those who have a low literacy have been shown to need the interventions the most. And low literacy was also not a social determinant that was examined in the participant pool.
So next, we're going to synthesize the evidence, conceptualize an intervention, and recommend approaches. So some features that we enjoyed in the 2 meta-analysis we looked at were the large sample sizes that increased power, focusing on prevention of alcohol consumption during pregnancy rather than reduction of alcohol consumption during pregnancy. The digital text intervention had high effectiveness and it was an easy mode of delivering an intervention. The varied population allowed the results to be applicable to many different people. Enrollment at any pregnancy stage increased the power of the studies as well. And the follow-up assessment after birth further added validity to the study.
Now, to best fit the features we hope to replicate, we chose the Text for Baby intervention as a starting point. This study shows great potential for promoting maternal and child health outcomes through mobile health interventions by linking them to reduced alcohol consumption. Pregnant women and new mothers who received evidence-based health information and support reported significant reductions in alcohol consumption, leading to long-term behavioral changes. The program effectively targeted underserved and high-risk populations and addressed social gradient of health using tailored text messaging system, resulting in improved maternal and child health behaviors and outcomes. Overall, we deem this study to have a significant potential to improve maternal and child health outcomes and reduce health disparities through mobile health interventions. Now, based off what we just discussed, we decided to modify the Text for Baby intervention.
So to give some overview on the Text for Baby study, the Text for Baby intervention targets many theoretical frameworks such as social cognitive theory, trans-theoretical model, and health belief model. Text for Baby specifically addresses self-efficacy and normative beliefs of the social cognitive theory. Text for Baby directly addresses these theories because it requires a baseline questionnaire of current beliefs, and the goal is that the health understanding will develop during the intervention period. The goal of the Text for Baby was to improve healthcare beliefs, behaviors, and clinical outcomes in pregnant women and new mothers. Text for Baby split participants into two groups, Text for Baby and usual care, or solely usual care as a control. The text included information about prenatal vitamins, alcohol during pregnancy, and importance of health visits. Text for Baby's participants were pregnant and currently in the military, with the average age being 28 years old and 70% Caucasian. As discussed in the key features to replicate, we would hope to have a larger sample size and more varied population. The results showed a significant effect of Text for Baby text reminders on pregnancy health outcomes and represents a promising future for digital interventions.
We had recommendations for the Text for Baby intervention on three fronts: the population, measures used, and intervention components. On the population, the sample inclusion criteria should include those who speak Spanish. The original focus on only English speakers excludes many potential beneficiaries from varying populations. The survey questionnaire should focus solely on attitudes, behaviors, and beliefs related to smoking, marijuana use, alcohol use, healthcare appointments, and health information seeking. These factors have an evidence-based impact on alcohol use during pregnancy. The questionnaire should also extend to partner, peer, and community perceptions, strong determinants as noted in the SEF. An actual alcohol intake should replace knowledge as an outcome measure and should be evaluated by an objective measure such as segmental hair analysis to reduce the risk of underreporting due to social desirability bias. For the intervention components, we recommend that text should also have an option to be in Spanish, and there should be a text to audio option for working mothers to retain them, which the original intervention struggled with. The control group must now also include advice on alcohol use, which solves an ethical dilemma, and messages should be tailored to the baseline survey responses, not just tailored to the date of enrollment and gestational age.
So in summary, the burden of alcohol intake during pregnancy in the United States is a large and preventable health concern. Interventions targeting the prevention of alcohol intake during pregnancy have been shown to be effective, especially digital text interventions such as Text for Baby. We suggest a modification to the population, measures, and components of the Text for Baby intervention to decrease the prevalence of alcohol intake during pregnancy. These are our resources. Thank you guys for listening. Does anyone have any questions?